Welcome back to the deep dive. Today, we're tackling a stack of notes, articles, and research that you shared with us. It's all focused on one absolutely critical topic, meningitis.
That's right. And our goal today is pretty straightforward. Cut through the density of these revision notes, pull out the really high-yield stuff, and help make it stick. Think of it as, refining that raw material into sharp tools for your revision, especially for this condition.
Exactly. We're going to unpack these sources together, highlighting what's most important and why. Okay, let's dive in. What exactly is meningitis, at its core?
Okay, so at its most basic, meningitis is inflammation. Specifically, inflammation of the meninges, those protective layers wrapping the brain and spinal cord.
And the notes really highlighted how you confirm that inflammation is happening, didn't they? Right from the start.
They did, yeah, and for good reason. The material emphasizes CSF analysis, analyzing the cerebrospinal fluid. That's the key diagnostic procedure. It's how you spot the inflammation and often figure out the cause.
Okay, so to anchor this for revision, meninges are the brain's wrapper. Meningitis is inflamed wrapper. And you check the fluid inside the wrapper, the CSF, to see what's wrong. Inflammation of the wrapper, checked via the wrapper's fluid. Makes sense. All right, so something causes this inflammation. What were the main culprits mentioned in the source material?
The notes outline the broad categories. Infections are the big one. Bacterial, viral, fungal, or sometimes, though it's rare, parasitic.
And among those, the sources called out some specific big players, especially the bacterial ones.
Absolutely. For bacterial causes, the notes really point to Streptococcus pneumonia, Neisseria meningitidis, and Haemophilus influenza. Those are the ones you really need to know. Viral causes, well, they're often the more common enteroviruses.
Right. Those three bacteria are definitely high yield. A simple way to maybe remember those bacterial baddies? What about their initials? SPNH. S for Streptococcus, N for Neisseria, H for Haemophilus. SPNH. Gotta watch out for SPNH.
That works. A good mnemonic definitely helps lock it in.
Okay, stepping back slightly, who's more likely to get meningitis? Did the notes highlight specific risk factors?
Yes, several were listed. Age is a big factor. Infants and the elderly are more vulnerable. Also, a weakened immune system significantly bumps up the risk.
Makes sense.
And then there's close contact with someone infected, especially in, crowded living conditions. That raises the risk, too.
And there were some specific medical conditions mentioned, too, weren't there? Things that make you more susceptible.
That's right, yeah. The notes specifically flag conditions like HIV and also having cochlear implants.
Okay, so if you're revising this, a good self-test question might be, who's in the high-risk group? And your answer needs to cover those age extremes, immunocompromised people, close contact situations, and then specific things like HIV or cochlear implants. Helps frame it.
Spot on. That's a great way to consolidate those facts.
Let's dig into what's actually happening inside the body then. The pathophysiology, how does this inflammation process unfold?
Okay, so it starts with the pathogen invading the bacteria, virus, whatever it is, getting into the system, into the meninges. This then triggers the body's immune response right there in the meninges, which leads to inflammation.
And what's the key consequence of that inflammation specifically in that location?
Right. Here's where it gets really interesting. That inflammation causes a flood of white blood cells into the CSF. This buildup of cells and the swelling, it disrupts the normal flow and absorption of the CSF.
Ah, okay.
And the result, increased pressure inside the skull, raised intracranial pressure, or ICP. A lot of the dangerous symptoms of meningitis come directly from this pressure buildup.
That link between inflammation and raised ICP is crucial then.
Okay, so given those symptoms like headache, stiff neck, what else might look like meningitis? What differentials did the notes mention?
Good question. The material listed several serious conditions that can present in a similar way. Things like viral encephalitis, that's inflammation of the brain itself, not just the coverings.
Also, brain abscess, a subarachnoid hemorrhage bleeding around the brain, and even some autoimmune disorders.
And this brings us back to that CSF analysis again, doesn't it? Helping tell these apart.
Exactly. It's absolutely essential. The CSF findings are often what help you differentiate meningitis from these other conditions, which, need very different management. The notes are clear on that.
Thinking bigger picture now, epidemiology. How common is it? Who gets it? What did the notes cover there?
So the notes gave an overview. Generally, bacterial meningitis is actually less common than the viral forms. Neisseria meningitidis was highlighted as a major cause of bacterial cases globally.
And there was a positive point noted, too, about trends.
Yes, a really important one, the impact of widespread vaccination programs. These have significantly cut down the incidence of some of the main bacterial culprits, particularly certain types of meningococcal and Haemophilus influenzae meningitis. That's a huge public health win.
Definitely good news there. Okay, so clinical presentation. If you suspect meningitis, what are the red flags? What signs and symptoms did the notes list?
Right, for adults, the kind of classic triad or more includes severe headache, that characteristic stiff-neck neutral rigidity fever,
Yeah.
and often sensitivity to light, photophobia. Plus, altered mental status, nausea, and vomiting can be key features.
And it's important to remember it can look different in infants.
It really is, yeah.
Yeah.
The notes point out that infants might just be really irritable, feeding poorly,
Yeah.
or have a bulging fontanelle, that soft spot on their head.
Less specific sometimes.
Exactly. And what's absolutely critical, and the notes really address this, is that meningitis demands immediate medical attention. It's a true medical emergency.
That urgency is key. Okay, remembering those adult symptoms. Maybe that phrase we thought of. My head and neck felt like mind puking. Headache, neck stiffness, fever, light sensitivity, mind altered puking. Head and neck felt like mind puking. Might help it stick.
Catchy. Whatever works for recall under pressure, right?
All right, so you suspect it based on symptoms. How do you confirm? What are the essential investigations?
Well, as we've mentioned a few times, the absolute cornerstone, highlighted throughout the notes, is CSF analysis. You get that via a lumbar puncture, carefully taking a sample of that fluid.
And what are you actually looking for in that CSF sample?
Several things. The cell count, how many white cells and what type. Are they mainly neutrophils, which we call polymorphs, or lymphocytes? Also, protein levels, glucose levels, comparing CSF glucose to blood glucose is key. And then microbiological cultures, trying to grow the bug.
Were there other supporting tests mentioned to back that up?
Yes, the notes listed others like blood cultures to see if the infection is in the bloodstream too, and imaging, like a CT scan. That's often done before the lumbar puncture if there's concern about raised ICP or focal neurological signs.
Right, safety first.
Exactly. But CSF analysis is still central to the diagnosis itself.
Now, that detailed CSF table in the notes, that's gold dust for revision, breaking down findings by cause. How do we interpret those patterns?
Yeah, that table is incredibly useful. What's fascinating is how the CSF really tells a story. For bacterial meningitis, the fluid typically looks cloudy. Glucose is low, usually less than half the plasma level. Protein is high, often over 1 gram per liter. And critically, the white cells are high and dominated by polymorphs neutrophils.
Okay, clear picture for bacterial. How does it differ for viral?
Viral CSF is usually clear, maybe slightly cloudy. Glucose is typically normal, around 60–80% of plasma, though the notes did mention exceptions like mumps or herpes where it can be low. Protein is usually normal or maybe just a bit raised. And the white cells, lower count than bacterial, and importantly, dominated by lymphocytes.
Lymphocytes for viral, polymorphs for bacterial. Got it. What about TB or fungal?
Those often have slightly cloudy CSF too. TB sometimes forms a fibrin web on standing. Like bacterial, the glucose is usually low and protein is high. But the key difference from bacterial is the cell type. Again, it's predominantly lymphocytes like viral. Often, though, the lymphocyte count might be higher than you'd typically see in viral cases.
That table is so crucial. So maybe a simplified way for revision. Bacterial, cloudy, low glucose, high polymorphs. Viral, clear. Normal glucose, lower lymphocytes, TB fungal, equisis, cloudy web, low glucose, higher lymphocytes. That polymorph versus lymphocyte distinction seems like a major takeaway.
Absolutely. Nailing those patterns is really high yield.
Okay, diagnosis made or strongly suspected. Management. What did the notes outline here?
The absolute priority, especially if you suspect bacterial, is urgent treatment. That means immediate antibiotics, viral forms, generally supportive care, rest, fluids, pain relief, and of course, prevention through vaccination is key.
The notes also listed those nice recommended investigations to do before starting specific management, right?
Yes, that list included things like FBC, CRP, coagulation screen, blood cultures, whole blood PCR for specific bugs like meningococcus, blood glucose ball gas, and the lumbar puncture, but only if it's safe, meaning no signs of significantly raised ICP or other contraindications.
And that urgency message carries through to management steps, too.
Emphatically. Urgent transfer to hospital for all suspected cases, no delay. And that specific instruction. If you suspect meningococcal disease, give intramuscular benzoyl penicillin immediately if it won't delay getting them to hospital. That if is important, don't delay transfer for the injection.
Right, get them moving. Now, the BNF antibiotic recommendations table, that was quite detailed.
It was, but it's structured logically. For empirical therapy, treating before you know the exact cause, it's based on age. Under 3 months, 4-FE cefotaxime, PLUS, amoxicillin or ampicillin, 3 months up to 50 years, 4-FE cefotaxime or ceftriaxone, and over 50 years, 4-FE cefotaxime or ceftriaxone, PLUS, amoxicillin or ampicillin again, mainly to cover Listeria.
Okay, so the age breaks are key for empirical choices. What if the specific bug is identified?
The notes list the main ones. Meningococcal gets IV benzylpenicillin or cefotaxime ceftriaxone. Pneumococcal and Haemophilus influenza both get IV cefotaxime or ceftriaxone. And importantly, Listeria needs 5-E amoxicillin or ampicillin, often PLUS gentamicin.
That's a lot, but broken down by age and bug helps, maybe for empirical. Cef plus Amox, 3, or cefceftri alone, 3 mg for 50 way, cefceftri plus Amox, 50 way. Just linking drugs to ages.
That could work. The notes also mention IV dexamethasone steroids, which can help reduce neurological problems later on, particularly in pneumococcal meningitis, though the BNF has specific guidance and exceptions.
Good point about steroids. And alternatives for allergies.
Yes, chloramphenicol is listed for those with significant penicillin or cephalosporin allergy.
Okay, that covers the patient. What about managing their contacts?
Crucial point, especially for meningococcal disease. The notes state prophylaxis is needed for household members and other close contacts, particularly those exposed to respiratory secretions, like kissing contacts.
And what do those contacts get?
The material specifies either ciprofloxacin or rifampicin, and it needs to be given quickly, within 7 days of the contact. Meningococcal vaccination is also usually recommended for these close contacts.
How does that differ for contacts of someone with pneumococcal meningitis?
Generally, prophylaxis is not routinely needed for pneumococcal contacts. The notes mention exceptions might apply in cluster situations following specific public health guidance, like from UKHSA.
Okay, so for meningococcal contacts, maybe remember close contact CR. Close contacts get ciprofloxacin or rifampicin plus vaccine advice.
Nice and concise.
Looking ahead then, what's the likely outcome? The prognosis.
Well, as you'd guess from the causes, it varies hugely. Bacterial meningitis is serious. It can be life-threatening, even with prompt treatment. The prognosis is guarded. Viral meningitis, on the other hand, is usually self-limiting. The prognosis is generally good for most viral types. So it really boils down to the specific cause, the patient's age and general health, and critically, how quickly effective treatment was started.
Time is brain, as they say. And even for those who recover, what about long-term problems, complications?
Yeah, the notes list some really serious potential complications. Things like permanent brain damage, hearing loss, which can be quite common after bacterial meningitis seizures and other neurological deficits. In severe acute cases, you can see complications like hydrocephalus, that's the CSF buildup, needing drainage, septic shock, and unfortunately, death. And if we connect this back, the potential for long-term issues like cognitive problems or hearing loss, even in survivors, just hammers home how vital that early recognition and treatment is. It's not just about surviving the acute illness, but preventing these often devastating long-term consequences.
That link is so important, maybe for remembering complication categories.
Yeah.
Brain, body, bad. Brain issues, damage, seizures, hydrocephalus, cognitive deficits, body-wide, septic shock, and bad sensory outcome, hearing loss, death. Just a quick checklist.
That works. Grouping them helps.
So we've really dug through these notes: definition, causes, risks, pathophysiology, differentials, epidemiology, symptoms, diagnosis, management, prognosis, complications, all drawn from the source material you sent in. Boiling it all down, what's the ultimate take-home message for someone revising meningitis based on this deep dive?
I think the key takeaway from these notes is that while meningitis covers a spectrum, from relatively mild viral to life-threatening bacterial forms, mastering the core concepts is really achievable and crucial. Recognizing those key symptoms, understanding what the CSF analysis tells you, and knowing those urgent management steps, especially for suspected bacterial cases, that's the high-yield information that makes a difference. The material you shared gives a really solid, focused framework for getting that right. And, this raises an important question to maybe think about further. Given how much impact vaccination has already had, especially on H. influenza and some meningococcal strains, what does the ongoing evolution of vaccine programs plus public health awareness mean for the future? How might the types of meningitis we see and how they present continue to change?
That's a really interesting thought to ponder, where this is all heading. Well, thank you for bringing this material to us, and thank you for joining us on this deep dive into these meningitis revision notes. We really hope we've helped make the key points from your sources clearer and hopefully more memorable. And if this kind of focused, high-yield approach is helpful for your revision, especially for exams like the MSRA, you can find incredible tailored resources over at passmsra.com.
Absolutely. And for a wealth of free resources, guides, and extra support to help you learn, definitely check out freemsra.com as well.
Thanks again for listening. Keep learning, keep revising smart.
Until next time.